Thank you so much, and thank you for the invitation. It's really great to be here. What a place to be. It's a bit chilly though, I must say. Anyway, I had a lovely day yesterday at the Acropolis Museum, etc., etc. And I just thought it would be appropriate or important for me first just to point out I'm not actually English, so I'm Norwegian. So I have nothing to do with theft of marbles or any other things. And I guess I would suggest the only stolen artifact that the British should just keep for now would be this one. So enlightening to hear the surgical view on this. Of course, radiology is actually mostly about helping the oncologists, I think. And the surgeons don't need us that much. They need to know the anatomy. I totally agree with that. Beyond that, perhaps not as much as is required in adult oncological surgery, because in pediatrics the oncological side is the most important bit of the treatment. Okay, so I'm going to try and make it really basic, and I'm sorry if that offends people. But I think it's really important to have the sort of fundamental steps in place. So just to avoid the following scenario. So here you have, typically we are dealing with very large lumps in pediatric oncology, and we get exquisite imaging. So we have patient scan, and the important thing is to avoid the third step being like this. Okay. So how on earth are we going to deal with when you see a big lump inside the abdomen, and that's going to be the main focus of my talk, the abdomen. If you see a big lump inside the abdomen, what is it? What can it be? Okay, so let's just have a look at the oncological options. So fundamentally in children, this is the kind of distribution that we are dealing with. So most of the oncology in children is leukemia. It's completely uninteresting, yeah, because it doesn't show up on imaging. So basically, just forget about that. CNS imaging, we will leave with Maria. So I'm totally not interested in that. Sorry. Lymphoma behaves exactly like it does in adults, so not interested in that. You see, it's very easy. So, and then we come to the soft tissue sarcoma. So now we are starting to take a little bit of interest. So this will involve, for example, rhabdomyosarcomas, very often in the abdomen, chest, etc., head and neck region, in the extremities, of course. And then neuroblastomas, you've seen examples of, and then we have the renal tumors, and then bone and germ cell tumors, and the rest we are not particularly interested in. Bracket around the liver. Liver tumors are really rare, important to know about, very rare. So mostly we just need to concentrate on this stuff in the middle. So the rhabdos, the neuroblastomas, the renal tumors, and the germ cell tumors. The bone tumors are sort of a special situation, I would say. So you see, already we are down to something a little bit more manageable, right? So. Remember the fundamentals. You have a child with a big lump in the abdomen. It may look something like this. Okay, right. A lot of vascularity going on here on the ultrasound, and then scanning through. You see quite a lot of sort of ill definition of anatomy. There is quite a lot of fatty infiltration, fatty stranding here. Okay, right. Just keep in mind, tumors are usually not oncological matters. They are very often infectious. Okay, so this is a good example of a burst appendix with a large appendiceal mass. Let's look at some further examples. So what do we have here? I know that not everybody here is a radiologist, but those who are can ask themselves, what do we have here? Is it a tumor, as in an oncological tumor, or is it something else? What do you think? Well, the first thing you see is that there is a scoliosis. Okay? Keep the basics in mind. If you have a scoliosis, that usually means you have an inflammation on the concavity of the scoliosis, right? Okay. So it starts smelling like not really oncological. Do you agree? And then let's look at some further MR imaging. So what do we have here? This is an ADC, apparent diffusion coefficient map. What does that show? Well, now many people I know would say, oh, it's restricted diffusion. So in other words, this is a malignant tumor, because they tend to be very low on the ADC. And then I say to my residents, you're not allowed to say anything about ADC before you have checked that you're actually looking at something that's alive. Because if it doesn't enhance, it's not alive. And that means what's restricting here is pus. Right, so there's no difference on ADC between pus and viable tumor. Okay, so if it ain't enhancing, you have to disregard the diffusion. Right, so just to explain this a bit more schematically, so abscess on top, neoplasia at the bottom. So you know they can look pretty similar on the T1 imaging after enhancement, after gadolinium. There may be pus in the middle of the abscess. There may be necrosis in the center of the tumor. There may be an enhancing rim of the abscess wall, and there may be an enhancing viable tumor component. Okay, the abscess usually has a little sort of fuzzy zone around it of inflammation, and we usually don't find that in neoplasia. If we do ADC now, what you will see is that the abscess looks very similar on the post-contrast and on the ADC, because you have pus in the middle, dead blood cells, they restrict, and then you have a zone of edema around, which is unrestricted on ADC. Okay? As you do ADC in the neoplastic situation, you get something different, because it's usually bright in the center. It doesn't have to be. But this you will disregard, because you know it's not viable. So whatever is not viable, you cannot say anything about on the ADC map. You just have to forget about it. And then what is restricted almost always in an untreated tumor is the viable part of the lesion. That is usually restricted. After chemotherapy, it's a completely different story, but I will leave that for now. Okay. So then, my friends, what are we looking at here? You know this already because you've seen some slides in the previous lecture, and George showed some nice axial slices, not exactly of this one, but of something else. This is clearly a very large abdominal tumor which breaks into the chest through the crosses of the diaphragm. It's a very typical growth pattern of something that you heard about in the previous lecture, and it is called a neuroblastoma. This is what a neuroblastoma looks like on ADC, and as you know, you are not allowed to even think about the ADC values before you've looked at the post-contrast image, which looks like this. And you can see that the entire sort of nodular mass in the retroperitoneum is all enhancing pretty homogeneously. And now you are allowed to look at the ADC, which is restricted, dark, similar to the spleen, yeah, restricted. So this is clearly a malignant tumor. Okay. So this is the basis for how you can, well, at least it gives some guidance as to how you can distinguish between tumor and inflammation. It's not always that straightforward, but it works pretty well. I need just a little hint when I have 5 minutes left. Is that okay? Because I tend to speak a bit too much. Sorry. So, if you have a tumor in the retroperitoneum, what can it be? Well, the list isn't really that long. So if we think back to what's common, okay, do you remember what's common? Neuroblastoma, nephroblastoma, soft tissue sarcomas, and yeah? Okay, and yeah. So in the retroperitoneum, neuroblastoma, as George said, typically an encasing pattern of growth. That is the usual. I will just tell you one secret. there's nothing specific about neuroblastoma and encasing growth. If you have a renal Wilms tumor that is ruptured and ruptures into the retroperitoneum, it grows in exactly the same way. Okay? So the reason that the neuroblastoma encases vessels is just because it's not restricted by any organ capsule. So anything in the retroperitoneum will have a... Do you agree, George? Yes? So you cannot make a histopathological diagnosis. You can just say that, well, it's something that's free in the peritoneum, so it's not arising from within the kidney, so it's most likely neuroblastoma. So that's the way it goes. Right. It typically metastasizes to bone marrow, sometimes to liver. It can go to lung, it can go to brain, go anywhere, but very typically and most often to bone marrow. Germ cell tumor is the next. Most of those are not malignant. And then you have the rhabdomyosarcomas. Let's look at what it typically looks like. What sort of sequence is this then? What do you think? This is a T1 weighted sequence because there's CSF is dark. Yeah, okay. But the kidney and the vessels are bright, so it must be contrast enhanced. Okay. So this is a flash sequence. It's a fast sequence where you can catch the contrast when it's in the arteries, and that's quite helpful. You don't need to give contrast, but I'm not going to talk very much about MR technique today. I'm just going to jump that. So aorta with branches, so both the celiac, the SMA, and the renal arteries are encased here. You can see the tumor quite well. When you give contrast, you get a nice enhancement in the normal tissues, and the tumor doesn't enhance quite that much, and that makes it quite easy to delineate it. In this case, you can see that tumor is encasing and stretching out all the major branches of the aorta, and it's growing into the left kidney. You also get some information about what it does to the blood supply of the left kidney. You can see it's enhancing much less than the right kidney. So clearly there's a compromise of the blood supply in this example. Okay, let's look at another patient. What do we have here? Okay, where is this tumor? Well, it's upstairs here on the left-hand side. It's very close to the left kidney. It's actually causing a dilatation of the pelvic heliceo system of the left kidney. Is this a Wilms tumor or is it a neuroblastoma? A quick one here. You don't have to shout it out if you don't want to. So ask yourself, is this a Wilms tumor or is it a neuroblastoma? It's difficult to tell actually if this is intra or extrarenal. But if you look at the bone met down here, that's not the metastatic pattern of a Wilms tumor, so it gives away the diagnosis of a neuroblastoma. Okay, so you can actually see quite a lot of bone marrow focal abnormality and also a lump here close to the bone, and perhaps a little bit of signal abnormality in the bone marrow of the spine on this T2 weighted image. What is always used for neuroblastoma is nuclear medicine, and there is a type of scan called an MIBG scan, which is pretty specific for neuroblastoma and very sensitive, although there are some exceptions there. And on this scan you can see a lot of uptake in the bone marrow, in the femora, in the I can't actually see from here, but I'm sure you can see in the liver, yeah, okay, and probably also in the skull. I'm not a nuclear medicine physician. I stick to the more well-defined part of imaging. Okay, what do we have here? Do we have a unilateral or a bilateral tumor in this case? This is a neonate. It's a neonate with an abdominal mass. Okay, unilateral or bilateral, what do you think? You can shout out if you like to, you don't have to. Okay. So, when I've shown this picture before, many people have said, okay, bilateral tumor, okay? No, it's not, because these are normal neonatal adrenals. Beautifully shaped, symmetrical, this is how they look. The tumor is actually this. That's tumor, okay? So that's a little bit surprising, in particular for those colleagues who do adult imaging, because they are used to tumors being bright on the STIR image. But in pediatrics, it's not the case. Tumor is usually intermediate signal in pediatric MR. Okay, so that's the paraspinal tumor, and you can see it's lifting up the left kidney to the side. Wilms tumor is not that common in the neonate, So you have a paraspinal tumor. It doesn't seem to be in the kidney. It's a neonate, normal adrenals, and this is again an example of a neuroblastoma. It looks like that. Yeah, this histology slide actually demonstrates why tumors are in children are low on ADC, and you can see they're extremely cellular. It's like looking at the slide of a lymph node or the spleen. So this is probably also a good explanation why these tumors don't have a very high signal on ADC, because there is so much cellular membrane in here that there is not a lot of space for water. And you know, it's the water that causes the stir to be high signal. Right. Now, we are getting towards the end of the neuroblastoma part here. This is another neonate with a tumor in the abdomen. This is a sonographic image of the same. It's quite difficult to know where we are looking, but I can tell you it's in the left suprarenal region. What do you see here? You see an abnormality, which is sort of pretty cystic-y, but with some septations within. We do MR. All the sequences in the MR look pretty similar. Thickish capsule, a little bit of septation, and the main material within the tumor is bright. What are we looking at here? Quick one, neonate. In particular, if there was a traumatic birth. Hemorrhage, exactly. So this is a typical example of neonatal adrenal hemorrhage. Important differential diagnosis. And let me just show you one more quick differential. Here we have another child. So it's a nice ultrasound scan here. I can pretend I did it myself. This is from the left. This is the spleen. This is the tumor. Well, actually, I have some graphics here. This is the tumor. And can you see the adrenal? Yes? Yeah, and the adrenal here clearly is separate to the tumor. The diaphragm? Here. The diaphragm is very, very close. You have a tumor that's just pushing itself up underneath the diaphragm by the look of it. And it's generally bright. Sometimes it has some little spots in, like sweet bread with raisins. That's what they look like. And if you do ultrasound here, for those who haven't got the diagnosis yet, the ultrasound looks like this, with some nice fat vessels going straight from the aorta into this mass. So it's a mass, but it's not a tumor. It's not an oncological mass. This is something congenital. It's something that you occasionally can see under the diaphragm, although it's usually in the lung. Got it? Yeah, it's so this is a foregut malformation. This is a bronchopulmonary sequestration. Okay, so it's quite nice to have seen that once, because it's very typical in that it lies along the diaphragm like that and leaves the adrenal normal. This doesn't need any treatment, doesn't need any biopsy. Just to be on the safe side, we look at it again in a month or two, and then everybody is happy. What have we got here then? What have we got here? Is this a renal tumor or is it a suprarenal tumor? Okay. And I'm sorry to be back to basics again and not challenging your intellects, which I know are huge, but I'm a very simple person and I like to talk about the simple things in life. Is this suprarenal or renal? You said this is important, because it's a matter of where the next step is. Do you take the kidney out or do you biopsy it? Okay, right? So what do you think? Well, the kidney, the cortex of the kidney is there, and that's pushed to the side by the tumor. So in a schematic it looks like this, do you see? So if the kidney is pushed to the side by something, then that something cannot be inside the kidney, it must be outside the kidney. I'm sorry to be so simplistic. What have we got here then? What have we got here? Is that an intrarenal or a suprarenal mass? Well, in this case, you can actually see a little bit of kidney going around the mass. Can you see? You can follow the cortex. This has a name in English. It's called the claw sign. Can you see? The kidney is the claws of the kidney around the mass. So if the kidney goes around it, all the way around, then it must be an intrarenal. Okay? So these are the fundamentals. What have we got here? Where is that originating? Can you see? That's liver, that's kidney, vertebral body. What's that? Head of the pancreas. What's the pancreas doing then? Well, the pancreas is really clawing around this lump. So this is a pancreatic tumor, see? This you see is very fundamental tricks of the trade. You know? The surgeons don't know this, so don't tell them either. You know. What have we got here then, guys? What is that? No, it's not the bladder. It isn't, because the bladder is here. Ah, right. These follicles, they belong in the ovary, okay. And you see, what's happening is that the ovary is actually clawing around this big cystic mass. So this is a cystic tumor of the ovary, see? Very easy, yeah? Just need to remember those radiology 101s. Let's talk about renal tumors a little bit. This is what I spend a lot of time doing. Almost all of the renal tumors are Wilms, but not all of them. So if you see a renal tumor on your scan, don't say this is a Wilms tumor. Just say it's a renal tumor, okay? Because you don't know that it could be a neurostoma in the kidney. It could be a clear cell sarcoma. It could be a rhabdoid tumor. It could be a mesoblastic nephroma of the kidney. You don't have to remember this. But just remember, don't call it Wilms, because you don't know. You don't have a microscope on your ultrasound probe, do you? Okay. 10% of them are bilateral. George just touched on that. So it's pretty common when you see tumor in one kidney that there's also tumor in the other kidney. Often you have to look very carefully to find it, in particular on ultrasound. Many of them go into the veins. I would say probably about 10% again go into the veins. And many of them metastasize to lung. And again, 10%. 10% seems to be in vogue with the renal tumors. If a child is less than 6 months old, it's not most likely that you are dealing with a Wilms tumor. You're most likely dealing with something called a mesoblastic nephroma. They need to be taken out immediately. They don't need any chemotherapy. They need a complete resection because they don't have a very high malignant potential, but they do tend to recur locally, if not resected completely. Right, this is what it would typically look like, and this is a sort of picture that I want you to give your surgeons, because in cases like this, it's becoming more and more common to do partial nephrectomy, or nephron-sparing surgery, as they call it. And if you can show the surgeon the anatomical location quite well, which is in the inferior half of the kidney, then and also say that the renal vein is clear or tumor, and also tell them the second thing, which is that there is another tumor in the upper pole there, okay, then the surgeon would be very, very happy with you. Yeah? Differentials. Infection is, of course, more common than tumor, okay, so just keep that in mind. Now, it depends a bit where you're working, doesn't it? Yeah? At Great Ormond Street, appendicitis is the rarest of all diseases, so we don't see that, you know. So everything depends on where you work and what the pretest likelihood of certain diagnoses are. Cysts and cholectasia, important, and nephrogenic rests, and nephroblastomatosis. If you have a situation here, these are two very abnormal kidneys, okay? The left kidney is huge, the right kidney doesn't look quite normal. There is no corticomedullary differentiation. Clearly, there is some homogeneous or monotonous masses growing within both kidneys. But what you do notice is that they are still reniform. They have maintained more or less the normal renal shape. And this is a typical appearance of what's called nephroblastomatosis, and that means you have fetal tissue occupying most of the kidneys. It hasn't matured yet into normal renal tissue. This is sort of an oncological borderline case. They often do give some chemotherapy and try to mature this tissue, and often that succeeds. At other times, they have to be resected and go on renal replacement therapy. On ultrasound, these can be quite difficult at times to see. This is another patient. This is actually a scan I did intraoperatively, and hence the very nice anatomical detail. Still pretty difficult to see this lesion, if I may call it. So this is a focal version of this. A focal version of nephroblastomatosis is called a nephrogenic rest. And they pose the same oncological challenges. How much time do I have left now, Georgia? 5 minutes. Okay, right. Then we better just do a little jump. Let's talk about something that you will definitely come across quite often, and that is, it's very nice to know about, because you can actually give a clear answer and a clear diagnosis. And to be honest with you, it doesn't happen very often. Yeah? I mean, all of us, we pretend that we can give a precise diagnosis, but the truth is we can't really. Right. But in some cases we can, and this is one example, and that's why I'm so happy when I see it. What is this? Not everybody has done a lot of pediatric imaging. Not everybody will know immediately what this is. But let me tell you. Well, the tumor is here. I can tell you that much. Tumor is here. Where is that tumor originating? Remember that? That's the fundamental bit. Where is it coming from? Is it coming from the thigh? Is it coming from the buttock? Is it coming from the perineum? Is it coming from the, I don't know. What do you think? Well, I can give you a clue. That's one ischial bone that's pointing to one side. That's the other ischial bone that's pointing to the other side. So if I can just step to the side, show you. It's gone like this. Whoop. So the ischial bones have been pushed apart, and that means the tumor must originate between them, or within. So it's a pelvic tumor. So it's a pelvic tumor that's presenting itself as an exophytic mass, quite large. And inside you have bone, and if you have bone inside a tumor, then it could be hepatoblastoma, but I don't think it is. This is a teratoma. Okay, so this is a typical presentation of a sacrococcygeal teratoma in a neonate. Okay, ischial bones, and here we have another one, which is in another part of the body. I can tell you that much. Yeah.
The opacity going up to the pelvis, to the right hand side pelvis.
Sorry.
The opacity goes up.
So my suggestion is that it starts here, and then it pushes apart the iliac bones, and then it comes out. Okay. So just fundamental anatomy. Keep that in mind, because when you see such a large thing, it's very easy to get blinded by it. So we still need to just calm ourselves down and say, go back to basics. Remember the anatomy, what is distorted. That gives you the origin of the tumor. Okay, so it's a pre-sacrococcygeal teratoma. On the right, you have a different patient with a different presentation of the same. How can we make a diagnosis? What is the giveaway here? It's in the anterior mediastinum, okay? Because it's lying between the sternum and the large vessel, so it must be in the anterior mediastinum, fundamental anatomy. What can it be? And people say, oh, it must be a thymoma. I have never seen a thymoma. Well, maybe once. I have seen T-cell lymphoma in the thymus, but I already told you I'm not interested in lymphoma. So it must be something else then. What is it? Well, what are these big black things here? They look a bit black, like that fat under the skin, don't they? So this is fat. If you have a tumor with fat inside, that's almost as pathognomonic as having a tumor with bone inside. Again, it's a germ cell tumor, it's a mature germ cell tumor, and they're called teratomas. So what is this? No, it isn't the bladder. It isn't the bladder. The bladder is here. That's the bladder. This is something else. This is rectum. This is bladder. So you have something in between. What is it? What is that? It's actually easier to see what that is on a plain film. It's a molar tooth. Okay? It's not swallowed. There's a young child. Not swallowed. What is it then? Well, if you have a mass with a tooth inside it, it's a teratoma. What is that? That's another one. That's a retroperitoneal tumor. The tumor is here. The ascending colon is here. Retroperitoneal. What have we got inside? We've got a tooth, and we've got a, I believe, a radius. Yeah, do you agree? Radius? I think it looks like that. Teratoma. What have we got here? We've got a tumor. What does it look like? Looks like a pregnancy scan. Umbilical cord. Fetus. Fetus in fetu. Yeah, the extreme end of the teratoma. All right. That's what it looks like on the CT. Many bones, most of them we can actually determine. So germ cell tumors, 3 types: epidermoid, dermoid, typically seen in the skull and the midline. Superficial lesions, not particularly interesting, can be removed by the surgeons. Teratoma, a bit more interesting, because they often present as large masses. Most of them are not malignant. Most of them are actually mature, 80%. They contain bone, they contain fat, they contain gut, respiratory epithelium, who knows? Anything. Some of them are a bit dodgy. They are sort of borderline, they're immature, and a very few of them are malignant. And they are the ones that are very important to image properly, because they can grow like this, which is another precoccygeal teratoma, except that in this case it infiltrates into the spine, and therefore it is not mature and not immature, it's a malignant. And they can contain any malignant tumor. They can contain bone and tooth and gut and lung and everything. They can also contain neuroblastoma and yolk sac tumor and sarcoma and you name it. Okay, so that's the end of the talk. And the most important thing, I think, this is the most important slide, because it takes some of the magic out of, and some of the fear out of imaging these children with large tumors. Because basically what I'm saying is that when you look in the abdomen, most of the time you're going to find one of these. It's either going to be a soft tissue sarcoma, meaning a rhabdomyosarcoma. You're going to find a neuroblastic tumor. Look at the retroperitoneal growth, the infiltration, the encasement of vessels, the metastasis to the bone marrow. A renal tumor, when you have a renal tumor, you have to look at the other kidney. Don't get blinded by the tumor. Remember the basics. Spend most of the time looking at the kidney that's normal to see if there could be a hidden little nephrogenic rest or a bilateral tumor in that one. Bone, well, that's not really in the abdomen. Germ cell tumor. Most of the time easy to diagnose because you see fat, bone, teeth, calcification, etc., etc. But in some cases can be malignant, and therefore they usually need to be resected. And not many minutes, I hope, over time, I will say thank you very much for your attention.